Good morning, everyone. My name is J.R. Morales, and I am an emergency nurse, and I've been practicing for more than 17 years now. I'm here to present to you epidural hematoma. Our learning objectives are understand brain anatomy relevant to epidural hematoma, explain the common causes and risk factors associated with epidural hematomas, recognize the clinical signs and symptoms of a patient with an epidural hematoma, understand the role of imaging studies in confirming the diagnosis, and the importance of timely and accurate diagnosis in guiding treatment decisions. Knowing the basic principles of management and identify the importance of basic assessment and monitoring of patient with epidural hematoma. Intracranial hemorrhage can be divided broadly into intraaxial, which is hemorrhage occurs within the brain tissue, such as intracerebral hemorrhage and intraventricular hemorrhage, and extraaxial, which is the bleeding that occurs within the skull but outside the brain tissue. These are epidural hemorrhage, subdural, and subarachnoid hemorrhage. So, what is an epidural hematoma? Epidural hematoma is collection of blood between the skull and the dura mater, most commonly secondary to a tear of the middle meningeal artery due to a blunt force trauma to the head. Middle meningeal artery supplies the vast majority aspect of the meninges, which passes through foramina spinosum. Bleeding will accumulate at the middle cranial fossa, which is located at the temporoparietal junction. Epidemiology and etiology. Highest among adolescents and young adults between 20 and 30 years of age. Most common cases of EDH are due to head trauma caused by traffic accidents, falls, and assaults. 75 to 95% of patients suffer skull fractures. And again, as I mentioned earlier, um, most common cause is blunt force trauma to the head, resulting to a fracture to the temporal bone. Rare cases of non-traumatic epidural hematomas are congenital AV malformation, coagulopathy, epidural abscess, and infection. Symptoms of epidural hematoma vary from coma in severe cases to momentary loss of consciousness in milder cases. Loss of consciousness and going into coma depends upon the severity of the impact. A patient that has severe trauma might get into coma immediately, while less severe impact, uh, transient loss of consciousness might happen, and then uh, consciousness might be regained. After 2 to 3 hours with continuous bleeding expansion of hematoma, uh, compressing the brain parenchyma resulted in deterioration of uh, condition which is called lucid interval. Also common symptoms include headache, vomiting, drowsiness, confusion, seizures, aphasia, and hemiparesis. Um, Unchecked hematoma expansion can lead to increased intracranial pressure um, with the clinical signs of anisocoria and Cushing reflex or Cushing's triad. These are hypertension, bradycardia, and respiratory depression or irregularity, resulting in brain herniation and death. So, going back to anisocoria, it's characterized by a difference in pupil size from one eye to the other because of the uncal herniation There is a compression of the third cranial nerve, which is the oculomotor nerve, resulting in dilation of one of the eye, uh, particularly the pupil. Let's talk about the Monroe-Kelly doctrine, um, which is the sum of volumes of brain, CSF, and intracerebral blood is constant. So the increase in intracranial volume also increases your intracranial pressure. And this Monroe-Kelly doctrine has something to do with the Cushing's triad. Cushing's triad are um, hypertension with widened pulse pressure, bradycardia, and irregular respiration. So basically, increasing intracranial pressure will result in decreased brain perfusion. So because of this, sympathetic nervous system is being activated to maintain cerebral perfusion. So because of this, um, there will be an increased systolic blood pressure. Uh, However, our parasympathetic nervous system uh, detects the increase in blood pressure via our aortic arch baroreceptor. So, because of this, vagus nerve is stimulated that leads to bradycardia. Respiratory depression or irregularity results in dysfunction of the respiratory system, particularly the medulla oblongata and pons in the brainstem, um, due to a compression because of severe ICP. So, diagnostic evaluation, um, imaging of choice is non-contrast head CT because of its speed, relative simplicity, and widespread availability. MRI has a higher sensitivity, but it's unsuitable to unstable patient due to slow process, and it's not widely available. Just a quick look comparison of epidural versus subdural hematoma on CT. So on your left, the lemon picture, that's your um, epidural hematoma. Um, Epidural acute clot is hypointense and has a lens-shaped appearance, while the subdural appears to be a crescent-shaped mass. Prognosis. In observational studies, um, the following variables have been associated with unfavorable outcome from epidural hematoma. These are low GCS score on admission or before surgery, presence of papillary abnormality, particularly contralateral or bilateral underactive pupils, old age, greater than 75-year-old, longer time interval between neurologic deterioration and surgery, and postoperative elevated intracranial pressure. Also, head CT findings that correlate with poor outcome as follows. So, hematoma volume more than 30 to 150 cubic millimeter, presence of midline shift 10 to 12 millimeter, mixed hematoma and hemorrhage indicating acute bleeding, presence of associated intracranial lesions such as contusion, intracerebral hemorrhage, subarachnoid hemorrhage, and diffuse brain swelling. So, the primary goal of pre-hospital management for moderate and severe TBI particularly uh, epidural hematoma, is the prevention and treatment of hypotension and hypoxia. These are two systemic insults known to be major causes of secondary injury after a traumatic brain injury. So, as a trained provider, below are the factors that may influence this decision to intubate the patient. GCS score less than 9, poor chest rise despite of the use of airway, repositioning the patient and basic adjuncts, um, SpO2 less than 90 to 93% despite the use of supplemental oxygenation, clinical signs of cerebral herniation, evidence of aspiration, and long transport time. Pre-treatment with short-acting opioids such as fentanyl when time allows to blunt the rise in ICP caused by adverse responses during RSI. Lidocaine also has been suggested as useful intervention to decrease the rise in ICP associated intubation, but um, good clinical evidence supporting this approach is limited. Etomidate is preferred over ketamine if there's a sign of cerebral herniation. The risk of head injury related death reduced with TXA in patients with mild to moderate head injury, but not in patients with severe head injury, according to the studies. Resuscitate the patients first before intubating, giving IV fluids, starting vasopressor, giving blood products. Don't intubate the patient as they are, um, as it will cause a serious problem. Decrease systolic event below 90 millimeters of mercury or below 65. We are doubling the mortality rate. Important to note that patient won't go hypotensive. Keep the patient normotensive or slightly hypertensive during intubation. For adults, the goal of ventilation include keeping an SpO2 greater than 95% and maintaining eucapnia with an end-tidal CO2 of 35 to 40 mmHg. Acute systemic epidural hematoma is a neurological emergency that often requires surgical intervention to prevent irreversible brain injury and death caused by hematoma expansion, elevated intracranial pressure, and brain herniation. So, craniotomy with hematoma evacuation is the mainstay of treatment. Burr hole has been used for acute epidural hematoma and may be life saving if access to neurosurgical expertise is limited or likely to be delayed. Glucocorticoid therapy is not indicated following head injury, as it has been associated with increased acute mortality. Seizure control with benzo and anti-epileptic, and maintain CPP more than 60 millimeters of mercury. Fever control to reduce metabolic demand. These are good management in an ICU settings. Managing ICP includes also head of the bed elevation of the head of the bed 30 degrees, um, brief hyperventilation to a PCO2 of 26 to 30 mmHg, and the use of osmotic diuresis with mannitol or hypertonic saline. In summary, epidural hematoma is a bleed occurring between the skull and dura mater. Most common cause is head trauma to the parieto-temporal bone, resulting in arterial bleed. Clinical presentation varies but should be suspected in any patient with significant head injury. Primary goal of pre-hospital management for moderate and severe TBI is the prevention and treatment of hypotension and hypoxia. Non-contrast CT is the primary imaging of choice to assess of an acute epidural hematoma, and craniotomy with hematoma evacuation is the mainstay of surgical treatment of symptomatic acute epidural hematoma. Thank you so much.